made them prompt that to put that in the note. Frequently, you could walk in the room and the kid's swinging in the ophthalmoscope trying to attack his younger brother, at which point in time, you go into exactly what Ilene said. But sometimes we can ignore some of the more subtle signs and say, oh, they're just sleeping or they're just taking a longer nap. And I think the differential for lethargy is just so huge. I mean, you've got CNS processes that could be there. You could have a child that's a missed hydrocephalus. You could have a bleach. You could have metabolic type diseases. You could have, hypoglycemia. You could have, boy, Ilene, you might have to help me out sooner versus later. You could have infections, probably fever. Fever does make kids tired. And if they've got vomiting and diarrhea and they've got some dehydration, they can be listless. They can have, decreased responsiveness. What else? Meningitis, of course, is a big one, although it's been a while since I've seen a really good meningitis.
It's surprising, isn't it?
Oh gosh, compared to my residency, yes.
Yeah.
I'm happy about it. It's much better not to see it. I hate seeing more abuse than meningitis, but I would say that's probably true at this point in time.
Well, Ilene, before you jump in, Ilene, I was just going to make a quick sort of expansion of what Anne was saying there. And I tell folks often, when you're documenting, I want you to be Hemingway. He was a genius at describing a situation. Like when you read a Hemingway book, you felt like you were at a bullfight in Spain, sitting in the sun, drinking red wine, and could smell the sweat on the back of the matador's neck. I mean, he was just so good at describing it. And so to say something like the child is swinging the ophthalmoscope in his hands, teasing his younger brother, or running down the hall laughing and screaming while the parent chases behind, that goes a lot further than when you document that a 2-year-old is alert and oriented times 3. So Ilene, some pro tips on that documentation, or a little bit further expansion of that differential diagnosis.
I think in terms of the differential, one of the wonderful educators where I work, Diane Birnbaum, likes to sort of have people split it into what is the most common and most likely versus what is the most dangerous, and at least choose your top 3. And obviously, this is going to be somewhat age dependent. A neonate coming in is going to be a lot different than an adolescent who comes in lethargic. But I think the top couple, likelihood wise, are always going to be things like dehydration or fever, things that are relatively easily correctable. And since some of the tests for lethargy are relatively invasive, this is something that even if I'm busy, it's more time efficient for me to do in a staged fashion. I mean, doing a lumbar puncture, getting the consent, that whole thing, it's time consuming. So I'm not going to just do everything at once in a shotgun approach just because it's not easy for me to do it that way. And so if the kid has a fever, treat the fever. If the kid was up all night, let him take a 20-minute nap if you have the room to do it. If the kid's a little bit dehydrated, give him some ondansetron and give him something to drink. And then if the child is still lethargic at that point, then obviously based on the age, and the history, you're gonna start thinking, is this an electrolyte issue with hypoglycemia? Is this non-accidental trauma or an accidental head injury? Is this something infectious like meningitis? Where I work in California, marijuana is legal now, and we see a lot of children and old people who are inexplicably lethargic to the point of being obtunded, where we're all saying, should we intubate this person? And it turns out that either grandma or junior got a brownie. So a urine tox is a very easy test to do that can sometimes help me figure out that maybe this is just cannabinoids and I just need to wait it out for about 4 hours and this kid is going to wake up and, we'll talk to the family about what the plan is to do next.
Yeah, the standard statement, doctor, don't just do something, stand there, right? So sometimes that's best, seizures or marijuana brownies, but both of those
Right.
things. So let's do this. I want to, I know KK and Lillian, you've been sitting there very, very patiently waiting to say something, but the initial visit, I think we've sort of explored some of the possible differentials, the way to document that. And, sometimes the patient's a little bit more tired than usual and you can't really figure it out. Even if you go with one of those concepts of lethargy and something, there just is no and. So what happened with our patient was sent home from the primary care provider, and then soon after, in fact, the next morning, was not up at the normal time, and that's what the image is here, and was then brought into the emergency department. So I'm just going to briefly summarize the initial visit, and we'll get to some of our decision points. And as we go through these bounce back cases on these conferences, and the way the book is formatted too, we have a presentation of the patient, we have a decision point, a discussion in a literature-based fashion, we see what the actual provider did, and then we move on to the next decision point. So here was the documentation. I'm not going to read the whole thing, but just the important parts. Yesterday was lethargic, however, was able to drink and slept through most of the day, but today has not woken up at all. They say negative as far as the lethargy and no fevers, chills, nausea, vomiting, cough, congestion, shortness of breath, or tachypnea probably is what they're talking about. 3 days ago was healthy. They said he was diagnosed with thrush, and we sort of know that. As far as the exam, they say that the patient was ill appearing, lethargic, not alert, and not responsive. So the neuro exam, they say posturing noted on the left side of the body, no response to pain of the left arm and leg. So all of a sudden now, this isn't lethargy, this is altered consciousness or really unresponsiveness, and incredibly more concerning than when the patient was seen at the primary care provider. So KK, I'm going to have you jump in right now. Why don't we go through now a little more of a focus differential with some focal neurologic deficit and an unarousable 11-month-old child? All right, we'll give her computer just half a second to buffer here. Oh, went down. Lillian, why don't I jump in, have you jump in here if you don't mind, while we're waiting for KK to get back online. Lillian, you know, I'm not sure how much of your practice is peds, but emergency medicine wise, we have this patient, all of a sudden a 4-alarm fire. Okay, KK, you're back. I'm sorry. All right.
So it was nothing but circles. I must have
Yes.
lost signal, so I apologize for that. So
all good.
same question stands.
Yes.
So now we have a completely different situation. I mean, before lethargy, we have this long list, altered.
Okay, I'm going to text KK to maybe switch rooms. Are you back, KK?
I'm back.
We
Sorry,
may
I'll
have to have
talk
you
faster so I don't go away.
answer this one, and then maybe, I don't know if there's a way to hardwire or to get closer to the router or something, but let's give us one more shot.
So this directs us more directly towards something intracranial. Is this an AV malformation? Is this a brain tumor? Is this trauma, non-accidental or accidental trauma? Is this some sort of intracranial hemorrhage? Could it even be something infectious that has caused this as well? Maybe meningitis, which has caused some edema on the brain, which could also cause a stroke. I mean, it's very unlikely, but uncal herniation seems pretty likely in this. We just have to figure out, why is this child potentially herniating, and why do they have a blown pupil?
Okay, awesome. Lillian, what can you add on to that here? We're obviously at a pretty significant crossroads here with the condition of the patient as well as interventions that we need to do.
Yeah, this is my greatest fear. This ends up getting triaged into some random little room when it actually needs to go into the trauma bay. Actually, I thought it was interesting how there's also that left anterior neck bruising, and then just the focality. I mean, it's really, until proven otherwise, it's, to me, non-accidental trauma. Unfortunately, that's pretty. This is very sad presentation.
So how about Ilene, and then Lillian, I'd like you to weigh in here also with this. We're at the bedside. We're seeing a patient who obviously is altered, who has some focal deficits. Do we go first for a brain imaging test, or we stabilize the airway first? Do we start with IVs? Do we get labs? Where are we going first with this patient? And I guess the focus question this really is, should we start with intubation?
I would feel uncomfortable sending this child to radiology without having the airway secured and an IV in place. I am very loath to intubate children, and kids who are seizing, I mean, I will let them seize for 45 minutes before I take that airway, and I'll bag them through, apnea from the midazolam that I gave them from their seizure. But this kid is obviously herniating. He's obviously going to need procedures done. He's obviously going to need a lot of imaging, and obviously his ICP is going to go up if he gets hypercarbic. He's going to have secondary damage if he gets hypoxic. Like, there's a lot of things that I need to control in this situation to make sure that he doesn't have additional secondary damage. And in this case, while aspiration risk is relatively low in kids, even that is important. I think getting the airway as soon as is safe, provided his blood pressure is okay and he's been resuscitated well, I think that's very appropriate.
So it seems like we should do what we do best at the bedside, which is making a clinical diagnosis. I mean, do we really need a head CT to tell us that something is going on, whether it is bleeding from non-accidental trauma or, I mean, I guess a mass or something else that's going on there? So yeah, the donut of death or circle of death or however we want to call it, definitely try to avoid that at all costs. Lillian, other thoughts on intubation? I'm even going to go a little bit of a branch point because it seems like, 10, 20 years ago, there was always this protecting the airway sort of thing. But I have to say that, and I'm guessing that you would feel this way also, Ilene, if you're, waiting a longer period of time. But, a patient who's post-ictal or even intoxicated, I'm not just like intubating every single patient in that situation to protect the airway.
That's probably true. I think the concerning thing with this is the fact that the pupils are so disparate that this is going to require a very high quality image. So I think by giving the medicines to secure the airway, you actually prevent further aspiration, hopefully, if this child is literally that unresponsive. And then it also helps you facilitate the rest of the workup to be able to take over and to be able to explain and take over from the family's perspective.
Right. My sort of thought on the aspiration was more like a branch point with like adults or other patients. This patient, obviously, I think aspiration is probably the least of our worries in this situation here, unfortunately. So let me just ask Ilene, and we're going to sort of do another little branch point because just like, Lillian, you recognized part of the documentation, the bruising on the left anterior neck and chin. The patient also has a fever, which is a little bit curious. And so I'm going to ask just a couple things about that. But before we do, Ilene, what are some other steps that you take at the bedside? Hopefully, like Lillian is hoping, that the patient actually did get put in the trauma bay, not in a room at the other end of the ED.
Yeah, I think you bring up a really good point. You're right. Aspiration in pediatric patients isn't a huge, huge issue. And this really is something very specific to trauma. Like, if this kid were obtunded for being postictal or an ingestion or something like that, you're right. I probably wouldn't intubate. And I think we sort of throw around that term, protecting the airway. But in point of fact, we're really protecting the brain, right? So to protect the brain, which we already know has damage and we don't want it to have more, we need to treat any hyperthermia, which this child has, either with acetaminophen or perhaps with cooling measures. We need to make sure that we have good access, and hopefully that will be an IV, but I know this child's been vomiting a lot, so it may end up being an intraosseous line, and that's fine as well. We want to make sure that we have our oxygen saturations kind of in the 95 and above range, and we want to make sure that the child is not hypercarbic at all, whatever that's going to require from a ventilatory standpoint. Certainly, I think some seizure prophylaxis is probably reasonable at this point. And even though the most data is for phenytoin, I think levetiracetam is very easy for us to give, and we often will use that instead, even in children. And then, given the fact that this patient does seem to be herniating, I certainly don't think that it would be crazy to give mannitol or to give hypertonic saline. The literature is probably a little bit more compelling for outcomes with mannitol, but it's so hard in trauma patients because we never know what else has been traumatized. And do we want to give something that can cause hypotension and then find out the child had an intra-abdominal bleed? So I think because of that reason, most of us typically reach toward 3% saline at a dose of 5 mLs per kilo and give that over about 20 minutes or so. So those would be kind of the main things that I would think about. I also, considering that we're thinking this is probably a non-accidental head injury, again, C-spines, I don't really worry a lot about in kids. The risk of an injury from a standard trauma is low. But the kids that get C-spine injuries and even non-bony C-spine injuries are these abuse victims. I mean, somebody usually took them and shook them, and their head is flying all over the place. They're thrown against a wall. I mean, it's terrible. So they very often have cord hematomas. So this is a kid that I would put in C-spine. Obviously, elevate the head of the bed a little bit and just make sure that the blood pressure is at least 50th percentile. 75th is probably the best if you have a child who probably has an intracranial bleed.
So when you talk about C-spine, you're talking about a hard collar, not a backboard, correct?
Correct. Oh no, I wouldn't want a
Okay,
backboard
just
because I
just
want to
clarifying.
elevate the head of the bed 10 to 15 degrees, and that's not going to help me. But I do want the kid in a collar, and I'm going to keep that kid in the collar not only through a negative CT scan, but given the extent of the damage, probably through a negative MRI as well. So I don't see this child's C-spine getting cleared during his time with me in the emergency department.
So certainly getting a head and neck CT, of course, and then keeping that patient in the hard collar. And look, we have people like you who are working in right a pediatric center of excellence, right? We have people that are working in the community where they don't admit any children. And before I actually bring the question to KK about the community center, I want to just recognize one of the participants, Daryl C. I'll just use your initial in case you had some HIPAA concerns, right? Daryl asks, are we worried about a carotid injury? Do we do the CT scan with and without contrast? Ilene?
A good question. I don't think that I would inherently worry about a carotid injury unless something was uncovered that would prompt me to worry about a carotid injury. So, of course, if I did the C spine CT and there was a transverse process fracture or a dislocation in the upper C spine or facial trauma like a Lafort fracture, one of those. Or if I didn't see anything on the head CT, I was so certain I would, but I didn't see any bleeding. And I thought, gee, why is this kid so altered without a subdural or something like that? But otherwise, I think I would not necessarily just scan the carotids. I do understand there's a bruise on the neck. And if you had a suspicion that there was a hanging or a ligature, that's probably not crazy to do. But if it's just kind of a random bruise, I think I might think about that as sort of having the same impact as a seatbelt sign, which is not typically an indication for carotid contrast imaging in children, although I certainly don't think that you'd be wrong to do it.
Right. I mean, those things are changing certainly from what it had been in the past. And there's also some new literature on strangulation injuries also, which it is, as I sort of remember them, I'm not an expert in that, but it's not quite as concerning as we had thought in the past. But certainly if there were signs of strangulation, I think a lot of people would go ahead and push the contrast because why not? And we're obviously not worried about things like contrast nephropathy in a 11-month-old or maybe in
Right.
anybody, right? Now, now Jack H asked about the fundoscopic exam, and of course, with an obvious case like this, with unilateral hemipresis, or if that's how we're sort of making that diagnosis, right? A clinical diagnosis of probable non-accidental trauma, or at least some bad intracranial process going on. But how about for the ones that we're just not really sure about? How helpful is that? Just like the red reflex or some sort of fundoscopic exam where you're actually looking at the fundi, looking for signs of increased intracranial pressure in an 11-month-old. Do you do that as part of your routine exam?
Yeah, I think as an emergency physician, you're absolutely obligated to do a high quality retinal exam with dilatation. No, I mean, the record, like, first of all, it doesn't matter for this patient, right? Because, we know what's happening. But legally, of course, it always does matter in the long run, because even though this is so obvious to us, legally, some of these are shockingly hard to prosecute. But the recommendation is to get a retinal exam within 72 hours. And honestly, I'm just not great at them, and I'm certainly not great at them when I'm freaking out and intubating and trying to think of all the other stuff I need to do and how am I going to sedate this child. It really legally should be documented by an ophthalmologist that has the ability to do so, maybe some pictures in the chart. It's not an emergency. This is something that can clearly be done on the floor, and I don't think I would take the time to do it.
Okay, so if I'm summarizing that correctly, not to do obviously in the emergency department, but that should be done at some point later when someone else is caring for the patient. Of course, we're getting a head CT at some point after the patient is stabilized. So the most important part we're going to see about that anyway. So KK, let me just sort of bring things over to you here. Although it looks like your internet went out again here for a second. I was going to ask about management of pediatric. Oh, there we go. KK, so management of pediatric trauma or possible non-accidental trauma in a community setting. I'm sure that you have seen that. I don't think that you work in a pediatric emergency department. Give us just a couple pearls or things that you've learned from experience as far as how you manage this type of patient.
Well, it's very different when when you don't have as many people to help. Of course, being
Okay, why don't we sort of move on here, and I will tell you what happens next. And are you back? Okay, so I said if you try to answer this one, and I'm not sure if you're able to move closer to a router or hardwire in, but
yeah. Okay, I'll be quick. So
oh, good.
it depends on how many people you have available. The first thing you want to do is tell the HUC, call to get more hands on deck, call to get a helicopter check, call the hospital that we're going to send the patient to, tell them, get me the Vocera phone, put them to my so that I can tell them what's going on real time as we're doing this, call the radiologist, call the CT, the lab, call everybody and tell them that this is urgent, that everyone take care of this faster than not. Because sometimes we work in critical, one doctor, one nurse. That's it in the emergency department. So you can always pull people from the floor, but depending on where you are, it's going to make a big difference. As you are walking into the room to resuscitate that child, you have to grab the HUC, with the nurse, and give them instructions to alert everyone and get everybody in line. And then as you walk in the room, of course, you do everything that you usually do, ABCs, GCS, you want to do primary, secondary survey. You want to maybe dares to come and do the second.
So I'll do is sort of add on a little bit to what KK is saying, and I really love the fact as far as the hands, well, getting the helicopter en route or the pediatric ICU, those folks actually have quite a bit of expertise and can absolutely be helpful if that resuscitation is still ongoing when they get there, if they can get there fast enough. So yeah, once you know that the patient is going to be transferred, there's no point in waiting until you call and talk to someone and you leave the room after you've resuscitated and get acceptance. Yeah, get that helicopter on the way. And most hospitals, I think, would have an arrangement for either trauma or trauma peds, that type of stuff to keep things going. So I'm going to tell you what happens with the patient here. And this is the medical decision-making note. They say the patient is presenting with a blown pupil and lethargy. Also had a fever. While here, I suspect there's an intracerebral injury. Based on my exam, I suspect that fever is likely related to intracerebral injury. Could also be potentially meningitis. So this is as the medical decision-making is written in real time. The findings on exam do indicate CNS injury. The patient was brought into our trauma room immediately. My initial exam demonstrates a blown pupil and poor protective reflexes of the airway. Blood glucose was initially low, although on the labs here that I'll show you in a second was 99. Bilateral IVs were placed by the staff, gave him D25, 2 ml, in addition D10, 20 ml. The blood glucose responded without any improvement in the mental status, and they decided to intubate the patient. So what I want to do is, before we actually talk about some of those specifics, this is our decision point A, and so we went through, these are the labs that I was just sort of talking about there. But before we go to our really in-depth discussion where I'm going to ask Ilene and Lillian to talk about some of those subtleties and pro tips as far as intubating children too, and initial event settings. And let me ask you, the white count is 20.1. This physician thought meningitis was on the differential. So, thinking about things now, one diagnosis, the non-accidental trauma, seems more obvious. But at the time, in real time, or maybe with the adrenaline shooting through the veins of the person who's at the bedside, right? That was one of their considerations. We do have a fever. We have a high white blood cell count. Explain why those things are happening if this is not accidental trauma and not from infection? And what are your specific thoughts if some antibiotics should be started on this patient?
I think first of all, this could all be consistent with a major head injury. You get demargination, you get an elevation of the white count that you can see with severe head trauma. You also can get hyperthermia, which needs to be treated, as Ilene was talking about earlier. From my personal standpoint, depending on where you're at or any place you're at, it never hurts to draw 1 to 2 blood cultures and push a blasted dose of antibiotics if you've got a kid with a blown pupil. So from a personal standpoint, giving a dose of antibiotics, a lot of times you haven't had time to get the kids' medical history. You know, maybe they don't believe in vaccines. Maybe they haven't been vaccinated at all and they've had a fever. So practically, until you get that CT scan, you're not going to be 100%, although I'd say you're pretty close to 100% just based on this physical exam. But it's never a bad idea to go ahead and grab couple of blood cultures, give a dose of antibiotics, cover the child. They can always stop them upstairs. And, you know, we don't even mind that when kids are being transferred in, you know, the single dose of antibiotics.
Yeah.
I mean, what do you think?
Yeah, we're not really worrying about antibiotic resistance on this patient. And in all fairness to the provider, I mean, to all of us, I think it really seems like obviously some sort of non-accidental trauma. But in all fairness to them, at the bedside, you know, sometimes some of these lesser things that are further down the differential, we're still really considering some of those things also. So I just put a list of some things that can cause fevers that are not infectious type of conditions, and it's an interesting list. It wasn't really going on in this patient here, certainly, but as far as all of these things, really, in fact, that diagnosis that we're most concerned about isn't even on here, right? So as far as the branch point, we talked about the white blood cell count. Ilene and Lillian, I wanted to do, and Ilene, if you want to go ahead and start, look, you know, things that we don't do commonly are more scary, of course. And I would encourage anybody who doesn't feel comfortable with pediatric intubations to find yourself a sim lab, either at your hospital in your town, and just like intubate that mannequin like 10 times in a row with all different types of instruments and VL and DL and curved and straight and everything that you can find. But at the bedside, when it is something, because we will invariably see things that we have not seen recently or don't feel incredibly comfortable with, Ilene, give us some pro tips, and then Lillian, I'd like you to jump in too, for step-by-step sort of where you're going as far as the intubation, which really to me feels like at this time, the most important thing we can do for this patient, in addition to the normal saline or the hypertonic saline.
Absolutely. And first, I just want to really agree with Anne. I have seen brain abscesses present like this. I have seen meningitis with strokes. I mean, meningitis is one of the most common causes of strokes, and a kid present like this. So, yeah, just antibiotics are so easy in kids. Ceftriaxone is a great anchor. You can push it. Just push that before, or, you know, as the kid's going off to CT, and you'll have a little bit of protection. And then if you find something like a brain abscess, you're not going to feel like you haven't treated them as expeditiously as possible. So in terms of the intubation, you know, I think that the biggest thing for me is get help and do what you're comfortable with. I mean, yes, kids have big heads and their cords are a little bit more anterior, but do the intubation technique that you are most comfortable with. I happen to be most comfortable with DL in kids since I still do DL. VL is not more advantageous in most kids unless they have a syndrome or some airway anomaly. But if that's what you do every day in adults, you want to go in there and see what you're used to seeing. And so use what you are most comfortable with, and either is fine. I think the real estate is a big issue in kids as well as the positioning. So I tend to put something small under the shoulders. My nurses are great. They're wonderful. They always run over with a big towel roll and put it under the shoulders. But for me, that's too much elevation of the shoulders. I want them up about a centimeter. So I will usually fold over one of those little baby blankets 2 or maybe like 2 times, and then put that under the shoulders, sort of the width of a hand is how much I want them elevated. And the problem is, a lot of times if you're DLing or even VLing, you end up pulling the kid's head off the bed if you're pulling hard enough to lift everything out of the way. So I like to have somebody help me and just hold the head and also hold the lip out of the way. so that once I have that blade in the mouth, I can actually see, because otherwise the mouth is so small, there's really no other room left. So those are the two big things that I like. I also have a very low threshold for dropping an OG tube or an NG tube, depending on what's appropriate in the situation. Kids desat very quickly, maybe a minute and a half for a small infant. And so chances are, if you don't do this every day, it's going to take 2 or 3 attempts, which is fine because kids are really easy to BVM back up to a good oxygen saturation. But once that stomach fills up with air, you can't get a lot of excursion and you're not going to be able to bag them up easily. You don't really want to find that out when you already have a saturation of 60 or 50. So I like to throw down an OG tube, empty out the stomach if it's taking more than one attempt, and just be ready and have appropriate expectations that the SAT's going to plummet quickly. And that's okay because I can BVM them back up.
And, really, Miriam Gachet-Hill, right, looked at the BVM versus intubations for EMS folks, right, and found that the BVM in that situation was actually better. So, there's no rush to intubate if you're adequately ventilating that person with BVM, that child with a BVM. I'm not saying that you shouldn't do it eventually, but it can give you a second to take a couple of deep breaths, make sure everything's all ready, and the suction of the whole thing, and you got the Breslow tape. And for your medications, etomidate and rocuronium?
Lillian, do you want to talk about meds, or do you want me to
I
talk about
guess
meds?
I have to admit, I'm still a sucks kind of person, especially for people with brain injuries, simply because you can actually examine them. The rocuronium, while it's great for doing sequential procedures, unless you're going to ablate the exam to the point where, once you transfer to the next hospital, they won't be able to do their exam. So I'm a traditionalist, and so I think, out in the community, thank God for the Broslow, thank God for cross-checking each other, thank God for us, because we don't do it so often, that we just bag and think and make sure we got it right, cross-check, make sure we have all the steps for the entire team, communicate in a closed loop way. And so when we do it hopefully the best way that we can in a calm, controlled fashion.
Lillian, how about for after intubation? I think for adults, a lot of folks are using propofol. There's, a lot of things that we're doing. Do you think that that's a, adequate and appropriate, good choice for 11-month-old?
So just like KK said, normally we're lucky that we are so close to the Children's Hospital that even within the region, we will make that phone call early. So even as prime and prepping, that if you can get them on the phone, if you're sequentially have to have them on a speakerphone, you can work those details out together. Personally, I guess I vaguely remember that propofol infusion syndrome was a bit more common with long-term with kids than it was with adults. So me personally, I probably, given how obtunded this child is, I probably will only give some doses of fentanyl. And then because of the possibility of seizures, maybe give some benzos. I probably wouldn't do any kind of continuous infusion, just intermittent.
Okay.
I'm curious what the pediatric emergency physicians think, actually.
Yeah.
This is what,
Other thoughts on that,
yeah.
right?
It's so tough because we just got dexmedetomidine usage rights in our emergency department. And now that we have that, I think a combination of fentanyl and dexmedetomidine is really nice in this type of patient. Obviously, I agree with you in terms of etomidate, and I don't think there's a downside to rock, but SUX is appropriate, and that's what we use for our traumas as well, even in the pediatric population. But before we got the dexmedetomidine, I used propofol for brief periods of time, and I did have one ICU physician not super happy with me. But let's be honest, propofol infusion syndrome is a real thing, and it is not okay. Like, it is high mortality. And if I worked in an ICU or I was watching this kid for 24 hours, that would be the wrong agent. But I'm not. I'm babysitting this kid for 2, 3 hours until they get to the operating room or till they get to the ICU, or in your case, till they get to the nearby children's hospital. And there's not a big downside to propofol during that period of time. So I think any of those options are reasonable. And particularly if you think that the child might be seizing, using something like propofol, or as you said, a benzo, is a reasonable option. I like pushing very high in the fentanyl in this particular situation. And for us, it's easy to do a continuous infusion. That's my preference because then I don't have to worry about it wearing off and then the kid gets agitated and the ICP spikes. That having been said, if that's not easy to do, I think bolus dosing is fine.
Yeah, and Eileen, I love what you said before about what you feel most comfortable with, because even if you're doing something that's not the best thing to do, it still might be the best thing for you to do. So if you feel most comfortable, this is what I would say. I don't know if everyone agrees, but with propofol or with a DL, like you're saying. I mean, me, for example, the day that VL came out, I started using that, and I've never done DL since that time. So I'm a VL guy, right? So, it's what each of us feels the most comfortable with is almost by definition what's best for us. So what I want to do, because Anne has a presentation at the end here, I want to move from decision point B to C. I'm going to tell you what the provider did here. Medical decision making note. Patient was intubated with, interesting, sucks, like you guys are saying, Versed and succinylcholine. A chest x-ray showed right mainstem intubation. So they pulled the tube back a little bit. The O2 sat improved, which is good. The patient was sent to head CT immediately after intubation and stabilization. And there was a right hemispheric infarct, is how the physician reported it, but also with blood in the sinuses. The official report says small areas of subdural bleed are seen on the right, hemorrhage along the falx. In addition, there's a non-displaced right calvarial fracture. And so the diagnosis here was non-accidental trauma. So in the next probably 2 or 3 minutes, I just want to go through a couple other very, very quick points. This is both for Ilene and Lillian. Now we have the diagnosis, and it's actually, our suspicion has been confirmed. It's not a brain abscess. It's actually what seems like obviously non-accidental trauma. There's a head bleed. The patient's intubated. Ilene, anything differently than what you talked about initially with maybe some hypertonic saline or mannitol in this situation?
I think we kind of knew what was coming, but certainly it's reasonable to be a little bit more aggressive. Once you know the answer, if you haven't done seizure prophylaxis, I would. If you haven't done the 3% or the mannitol, I would. Certainly, there's nobody on earth that isn't getting neurosurgery on the phone given this scenario, but this is definitely an indication for an ICP monitor, and that will help you with your blood pressure management as well.
Gotcha. And like Casey said so well in the beginning, is getting that helicopter initially right, off the ground and on the way there, or if it's a ground crew, getting them off the ground on their way there also is a really super good idea. Lillian, other things to add, and then I'm going to have Anne give her presentation. We'll have a little bit further time for discussion at the end here. But Lillian, anything to add at this point? We have the patient intubated. There's IV access. We're sort of waiting for that transfer.
Being simple to help the brain. So keep the head of the bed elevated, and then control that fever. So because even the brain injury causes the pyrexia, to go ahead and start IV acetaminophen or rectal acetaminophen to get the temperature under control, head of bed up, and then well sedation. So whether we choose intermittent bolusing or continuous, to make sure the brain gets to get some sleep, and so it's not metabolically at risk, along with treatment for the impending herniation.
Yeah, we actually talked last month about therapeutic hypothermia, and about how actually with the newest study, which seems to be the definitive study, that's not really helpful, but certainly correcting hyperpyrexia is helpful. And I think everyone would agree with that. So different ways to do that is super important. We also have that hard collar in place like we had talked about initially. So what I'm going to do is just tell you what happened here is, the patient was transferred to the local children's hospital with the diagnosis of anoxic brain injury, occipital skull fracture, intracerebral hemorrhage, and the children's hospital called and then spoke. Social worker at the initial hospital is going to contact the children's hospital social worker, and an investigation was going to be then initiated. So unfortunately, super, super sad case. This is one of the articles that Anne's going to talk about. A article with probably the best title of any article that it's ever been. Those who don't cruise rarely bruise. So what I'm going to do is come out of this here for just a second and put on Anne's PowerPoint, and then Anne, I will turn the floor over to you.
And I will be the fastest talker you've ever met so that you get a chance to make comments at the end.
Right,
I'm
exactly.
darn fast, yes. Not as fast as Mike, but I'm working on it.
I've had a lot of practice.
You're good at it.
All right. Okay, and you can just tell me when to go to the next slide.
I'll go to the cute slide. So first, this is a very overwhelming and sad topic and a difficult topic. But one of the things I wanted to kind of end this with, and Mike and I had talked about this, is what can you do about it? And what you can do about it is recognizing them when they have minor injuries so that you get them referred to the children's hospitals before we're looking at a kid who's got major injuries. It's been pretty well reported, you can go to the next slide, that children that present that have been abused, a lot of them, up to 30%, had a previous sentinel injury. And so it's really important that these early injuries are identified. The most common early injuries that we're seeing, which is why if they can't cruise, they shouldn't bruise, bruising was number one, intraoral injuries and other injuries. And it was the kids that are less than 7 months of age that were highest risk. Next one. So there's a couple of things that I just want you to think about. Make sure, one of the things I always find interesting is, and I always get concerned when you walk in and it's warm outside and the kid's completely covered. I feel the need to take their clothes off. So please be sure to take off, things that are up close around the neck so you can look and see if there's any neck bruising. Make sure you look at the front of the child's chest. They should not have any bruising on the torso, ears, or neck. So if you take and, they'll have those onesies on, you got to take the onesie off. You've got to look, because if they've got bruises on their abdomen, bruises on their chest, you got a problem. And if the kid's smiling at you, that's the time you're going to be able to make a difference before they have another event that might take things further. So this one is the 10-4 rule, which is any bruising of the torso, ears, or neck in a child 4 years of age or younger, or any bruising anywhere on a child 4 months of age or younger. Next one. And this is just a reinforcement of that. The other area that really, I hate to say it, but abusers have gotten smarter. So that, you're not going to be lucky and see bruises to the face or bruises. They know better than that. But if you can take their clothes off and look at their back, look at their butts, look at their chest, look at their belly, those are going to be bruises that if you can identify them and the child's 4 months of age or younger, they shouldn't be there. Next one. So this one, accidental or non-accidental? Let's keep your audience involved.
Yes,
Yes,
right, exactly.
It's non-accidental. Yes. Ear bruising is one of the ones to find. This is a pattern bruise, so this is also symptomatic of abuse, and this is you can see the distinctive pattern, which indicates that they've used a whip of a certain type, and that's going to be another one that's going to be concerning for abuse, or actually it is abuse. Anytime you see a burn where you've got this degree of depth, what do kids do? They're not stupid. They stick their hand in hot water. The first thing they do is pull the sucker out. So if you've got a kid that has equal depth of burns on hands or feet, that's very concerning for abuse, because they would not maintain contact. Be particularly concerned about hands and feet and butts in kids that are potty training, because that tends to be a time when people get frustrated with their kids, and that can be a means of punishment. Next slide. And this is one from potty training. And what do you notice about these burns? They're in the creaks. So if you've got a kid that they're holding straight down into hot water, you're going to have this pattern of symmetric burns, which is not going to be common with accidental. Accidental should be a spray type pattern with disseminated burns, not evenly distributed. This is my favorite, anger management. When angry with someone, it helps to sit down and think about the problem. I think my dogs do this to each other all the time. Next one. This I wanted to just briefly mention. There are also abusive fractures that I want you to think about. People will come up with some really good stories, but non-ambulatory children should not break long bones. And I've actually, through the years, Ilene can give her opinion, but I've just given up on trying to not. I just tell them if there's not a problem, there's not going to be a problem. Femur fractures, tib-fib fractures, humerus fractures, particularly humerus fractures, those are not normal in kids that can't ambulate. And be conservative with them, because if the child's smiling at you and doesn't have any evidence of head injury, that's the time we can do something about it, or hopefully that's when we can intervene with our resources and make a difference. Rib fractures are, I'd say, pretty much pathognomonic, especially if they're posterior rib fractures for abuse. Next one. And this is just the corner fractures or the bucket handle fractures. This kind of injury is extremely rare from accidental injury. So if you see this, your radiologist will call you, or if you see it, this is abuse. It's a twist. And so this one is pretty much, you know what somebody's done to this child. Next one. And you will get these on, and then go to the next one. You will get these on scalable surveys. So anybody that you're concerned about, one of the things, I know they take forever, and I think, what is it, 21 images, but they are so valuable. You know, I had a kid I saw one time, and we got a chest x-ray on it and showed 3 posterior rib fractures. And thank goodness the kid looked okay. And then we did the skeletal survey and we found a humerus fracture, a femur, you know, it was just the time to get this information. But posterior rib fractures are caused by violent squeezing. And if you ever see those, do not ignore that. That is an indication that this child has been severely squeezed. And it's going to be highly specific for physical abuse. Unfortunately, this is kind of what this patient had. Next slide. With the title of abusive head trauma. I don't care what you call it, it's really bad and they've hurt the kid's head. These are things that do not cause abusive head trauma, although the blessing of being an emergency medicine doctor with a kid with a blown pupil is you're not really going to be negotiating with parents. All you care about is the kid at that point in time. And so you're not going to be saying, okay, tell me exactly what happened, because you'll get that information, you'll document it, but that's not your priority. But short falls, particularly under 3 feet, do not cause that kind of injury. Bouncing a child on your knee, common keep going back there. Yeah, immunizations. These are just some of the things that people will tell you. A 2-year-old playing with a 7-month-old does not do that kind of injury pattern. Next one. These are the common presenting scenarios. And the reason I want you to think about it is, as you are going through that case, you know, lethargy and thrush, they come in and they trick you. And so it's not that they trick you. You're smarter than this. The problem is people are lying. And whenever people are lying and not giving you information, you are in a tough spot. So you have to kind of say independently, what am I seeing? Infants with bruises. We've already said that under 4 months of age, they should not have any bruises. Think about it during your worst viral season when you've got vomiting without diarrhea. Is there evidence that I should go look at this child's head? Is there something here that should make me more suspicious? My only concern with bruies, and this is my only concern with bruies, I think it was a brilliant move by the AAP, is that the one thing we're scared to death to miss is an abusive head injury. So if you've got a child that has an event, especially if it's witnessed by someone in the house that maybe wasn't the person that brought them in, you really need to consider abusive head trauma in that situation. And seizure without fever, but I think that's easy. Inconsolable crying, you start finding hidden fractures, you're going to follow along with that. Also remember, our developmental delay kids can be older and be abused. You've got a 3-year-old who's nonverbal, who's maybe bedridden. They can get very frustrating, and people who do not have good control of anger management can use excessive force with them. So be particularly protective of those kids that can't protect themselves. This is just a definition of abusive head trauma. What I want you to remember is none of this is typically a one-time event. And I don't know what goes through these people's minds, and I really don't want to know, but usually at least the literature it seems to be progressive. So they get away with one thing, then they do something else, then they do something else. So your goal is to stop them before they do something permanent. So if you see something that's suspicious, you want to be more aggressive to protect the child. Next one.
Why don't we do like just the next couple here, then we'll give some closing thoughts so we can end by 9.
This is a good place to stop, because this just kind of goes through some of the subdural hemorrhage, and then it talks for the retinal hemorrhages.
Okay, awesome. All right, yes, and I'm glad that you said that, because I wanted to make sure I got that slide up there to
Yes,
show
and get there. No, that's good, Mike. That's a good place to stop.
You don't want to stop on that one, Ann? Right.
I like that one. I'm a pediatric person. Come on.
Yeah, right, exactly. So let's get some closing thoughts from everyone. I think we have about 45 seconds per person. Lillian, will you go first?
When you see what you know, do what you know, and call for your friends and children's early.
Yes, there's no shame in calling for help in this game. Absolutely. We're street smart. We're smart too, but being street smart in a lot of ways is even more important. KK.
Yeah, so I think it's important that we are the ones that call Child Protective Services. The first physician is legally responsible for that. You always assume that the Children's Hospital will, and they usually do. But if something falls through the cracks, they're going to go after the first doctor. And so just be redundant. It's better to be redundant and protect the child. Call them yourself.
Okay, Anne, you've had more time to think of your brilliant closing thought here, but tell
No,
me
I differ.
maybe before
I look for sentinel injuries. Look for those bruises. Look for those injuries that in a good looking child can help you identify someone before they end up in that repetitive abuse problem that ends up with the abusive head trauma.
Right, and those are the tougher ones, obviously, when there's subtlety to it. So those suspicious things, and I mean the things that I take away from your talk, the bruises to the ear. This child had a bruise of his neck of the case of the 11th one that we're looking at. So getting that child undressed, especially they're coming into the summer, all those things are vitally important. Our chance to prevent something bad from happening. I mean, good job for the resuscitation, but prevention is obviously even more important. All right, Ilene, all the pressure's on you for brilliance now. Even more
Brilliant.
brilliance than you've already given us so far.
I don't think I have more brilliance than Anne's talk. I love that. But I would say don't forget about the abdomen, because when people often abuse their children because they have anger that they just can't control. And once you can no longer get satisfaction by picking your child up and shaking them as hard as possible because they're too big to do that comfortably, many people will go after the abdomen and they'll crush the child's abdomen against the floor, against a wall. So toddlers often will present with fatal abdominal trauma, just as infants present with fatal head trauma. We are very careful about CT scans in kids, but in the child described in this scenario, Cody, I mean, for a kid like that who's so sick, light him up, find every injury, scan everything, right? For a kid where your suspicion is a little bit lower, you may want to send off an amylase, LFTs, a urine, and if AST or ALT are greater than 80, if there's an abnormality of your amylase or lipase, or if there's blood in the urine, then light them up. I mean, the risk of radiation is relatively low compared to the risk of recurrent abuse.
Thank you, all the panelists, especially for taking your time and the preparation you did for this. And thank you to all the participants for sharing an hour of your evening with us. I know I am smarter after hearing all the expertise in this room. And unfortunately, obviously, a very tragic case that we presented here, but one that's vitally important because when we do have that opportunity to prevent something bad from happening, that's where we can really make a difference. Next month, we have another case. We move from our airway arrest, the first 5 chapters, we move to our section 2, which is the breathing and pulmonary section. Don Yulee is the section editor of that section, and we have some very, very good cases. The first one was a patient who came in full arrest, later found out that there was unilateral leg swelling. So we're going to talk about a lot of things, literature with PEs, thrombolysis of patients in arrest who might have a PE, as well as those type of diagnoses. So if you want to sign up for that, we'd love to have you. You can go to the website embouncebacks.com, and there's a one-click link that you can sign up right there. Tell your friends, and we, again, really appreciate you coming. Thank you so much to everyone, and have a great night.